This is incredibly meaningful work for me. I'm very passionate about it because I have been living with type 1 diabetes for more than a quarter of a century. And I have definitely benefited from the innovation that's happened in the diabetes world over the last 26 years, including having a very healthy pregnancy and now a 12-year-old daughter. So I now use my platform to educate and advocate for people like myself and for the millions of others who need and deserve support. I think focusing our efforts individually and as a society on healthier choices and behavior changes is critical. There are small things that can help prolong or prevent diabetes, but also those same things can really help the management of diabetes should it develop. So, I think it's just very important that, we all try to get up and move a little bit more, that we're making healthier choices, and that we're all doing our part, in the decision making that we have access to. There's a lot of barriers to access. Sometimes it's insurance, sometimes it's mindset, sometimes it's convenience. And so there are still far too many people in America who don't have access or comfort with these technologies and these medications to really be managing their glucose and their diabetes well. We know that information is power, and CGM for people with diabetes is the information that's power.
If we had a less sedentary population, if we had less obesity, and I am not blaming, please understand that, because I don't think someone wakes up and says, I want to have type 2 diabetes. But with the advent of more processed food, more fast food, I don't know about you, but I haven't moved away from the computer today. And tomorrow I'll see 15 patients virtually, and I'll be sitting in front of a computer. So there are things we should be doing. Every patient deserves to be on continuous glucose monitoring. I believe it's a right. I don't believe it's a privilege, and it doesn't matter what therapy, because we know the behavioral change from the data we see on continuous glucose monitoring can lower the A1C independently of anything else we do. Primary care are the people who are going to manage the majority of people with type 2 diabetes, and in some areas, they're also going to manage type 1. If you do a figure stick at 8 a.m., but don't do one again till 8 p.m., I have no clue what's gone on all day long. I don't know how to help you. If you tell me that you're having low blood sugar sometime during the day, I don't know how to help you. But if I have the continuous glucose monitoring, which tests constantly, like every minute, and uploads, I can go look and see, and I can be of assistance and help to you. I don't go home with my patients at night, and I always say that's a really good thing for them and me. But someone has to own their diabetes, and that's the person with diabetes. And so if I give them CGM, I have now given the tool to understand their diabetes, to manage their diabetes and intervene. The pumps are now opening up, as it should, to type 2 diabetes. So one pump has already been approved. We're looking forward in 2025 for that to be approved as well. And it's a different subset of individuals that will need a different type of education, because when they came to the table, we didn't give them the same type of education as we did with type 1 diabetes. You have to start thinking smarter about how to help our colleagues to help all the people with diabetes.
We've worked on just about every device that's on the market currently here in the U.S. and we try to focus our research not only on making sure that these are safe, effective, and advantageous to patients and help their quality of life, but we also really want to make sure it's translatable to routine practice. So we spend a good deal of time working on how can we get this out in the hands of endocrinologists around the country, around the world. What about primary care? Maybe some other providers that might not be as familiar or spend as much time in the diabetes space. So we spend a good amount of time on implementation as well. Diabetes it's a chronic disease that patients manage on their own. They don't see, they see us a handful of times a year, but they're living with it every day, making decisions about what to eat and how to exercise and their sleep and stress and everything you can imagine that goes into your daily life can be impacted by diabetes. Where we have these wonderful tools, these great medications, and all of these systems that work together. By and large, yes, they're expensive, but they should be covered. We just now have to train the folks who are going to help patients implement it and help them just get familiar with it, not be afraid to increase insulin or increase the types of medications and the intensity of management. I think that's the next phase of this. I think the one thing that we're a little late in acknowledging, but starting to now, is the psychological and emotional burden of diabetes on the individual. Like Davida said, we don't go home with patients. This is a 24/7 disease that there are so many variables and things that can go right, but there's also things that can go wrong. And this, we don't want these technologies to make it harder to live with this disease. So thankfully, as we've started incorporating this into almost every study that I'm a part of, we've seen that reductions in burden. Looking to the future, where 90% of people with type 2 diabetes are managed in primary care, these things will have to be simple to get primary care buy-in for prescribing and managing and implementing these and safely deploying them in their populations. The good news is there's some research to show that primary care providers are open to the idea and actually feel comfortable prescribing and ordering an automated insulin delivery, because they don't have to know all of the minutia of settings and basal rates and so on that we've been so accustomed to with older pumps. I think there's this mentality that people have to start at the most simple thing, or the least sophisticated advanced thing, and then sort of fail their way up to the well, we've tried everything else, now you qualify for this pump. And to me, it's almost more like, this is just a different way of managing it with insulin. So if we've decided that you need to move on to insulin, you could do it with basal insulin, you could do it with basal and 1 shot a day at meals, or we can try to automate it. And I think this is something that should be considered at the get-go, rather than having people, try one and not do well, because that just gets discouraging. It takes time, complications build up, and in the end, it becomes more expensive. What we've seen is that this assumption that everyone needs to be super savvy with smartphone apps and uploading to the cloud, like all of those things that we assume, you're not going to succeed on this unless you really know the ins and outs of insulin physiology and how sensors work. That's just out the window. I think we've just seen that patients can just put these things on, and they're pretty intuitive, and there's enough kind of give or flexibility with the algorithms that they don't have to be perfect at carb counting. They don't have to be perfect at anticipating exercise or sleep. That ability for the algorithm to adjust based on the ambient glucose really kind of can pick up some of that slack that we otherwise would have placed that burden on the patient.